Chapter 21, Child, Partner, and Elder Violence. The nurse is often the first point of contact for people experiencing family violence and is in the ideal position to contribute to prevention, detection, and effective intervention. All forms of interpersonal abuse can be devastating. Abuse can take the form of emotional, physical, and sexual abuse and neglect. Recurrent emergency department visits for injuries attributing to being accident-prone. Presenting problems reflect signs of high anxiety and chronic stress, such as hyperventilation, panic attacks, gastrointestinal disturbances, hypertension, physical injuries, depression, stress-related conditions such as insomnia, violent and nightmares, anxiety, extreme fatigue, eczema, and loss of hair. All these are signs of physical and emotional issues, but possibly also a sign of violence. Domestic violence is extremely complex. There's no single theory that explains domestic violence. It's most likely the interaction of societal, cultural, psychological, and neurobiological factors. Social learning theory is the learning theory or intergenerational violence theory of family violence that relies on role modeling, identification, and human interaction. Child learns violence as a behavioral norm. Societal and cultural factors such as poverty and unemployment, communities with inadequate resources, overcrowding, and social isolation of families can all play a factor. Classic frustration and aggression hypothesis is when frustration is high in response to a social situation, aggression follows. Not all individuals respond to frustration with violence. Some respond with despair, depression, resignation, or try to change the situation. Patriarchal theory is the male dominance in our political and economic structure enforces the differential status of men and women. In many subcultures, women are viewed as belonging to men. They're subservient or are kept relatively powerless. The World Health Organization has information on female genital mutilation. That is a horrible practice in some countries, but it's considered a normal there. The patriarchal theory, male dominance in the political economic structure that enforces the differences between women and men. And then in subcultures, women are viewed as being subservient or belong to men. Personality traits usually cause abusiveness. Legal or illegal drugs and alcohol may coexist with family violence. Some abusers argue that a loss of control, but it is not supported by behavior, as is evidenced by perpetrators of violence most likely choose not to hit bosses or policemen, no matter how angry they get, but yet they use the excuse, I lost control, when it comes to hitting another woman. Abusers often plan where violence is going to occur in the home, such as in home, and when there's no one else around, and also how, by leaving no visible marks on the person, on the victim. So they are choosing not only when and where and how they're going to perpetrate this violence. Other psychological factors include some of the following traits, such as low self-esteem, poor problem-solving skills, having a history of impulsive behavior, hypersensitivity, they see themselves as a victim, and narcissistic. Everything centers on themselves and they lack compassion. People with aggressive traits are usually immature, although some are able to put up a mature facade to the outside world. Harming a child is child abuse. Most states will recognize the different types of abuse, and those are physical, neglect, sexual abuse, and emotional or psychological abuse. Children younger than 4 years of age are usually the most vulnerable out of children. The Child Abuse and Prevention Act is any recent act or failure to act on the part of a parent or caregiver that results in the death, serious physical harm, sexual abuse, or exploitation, or any act of failure to act that presents an immediate risk for serious harm. Each state is responsible for providing its own definition of child abuse, and the definitions must meet minimum standards of CAPA. Assessing a child, you want to reassure children that they didn't do anything wrong. They're likely to think that they were the cause of a problem. Children should not feel pressured to talk. The questions should not be leading questions. Children may express experiences through role playing, such as with dolls or drawing out a picture. Never want to suggest answers. Again, no leading questions as well. Don't promise that everything's going to be kept secret, because as we know, we are mandated to report this. And don't react with shock to anything the child might tell you. And don't force the child to undress or to be examined. So interview guidelines or open-ended questions are the best, working with children. Possible questions for a child would include, how did this happen to you? Who takes care of you? What do you do after school? Who are your friends? And what happens when you do something wrong? Characteristics of abusive parents, maybe a history of violence or neglect, emotional deprivation as a child themselves. They may have low self-esteem, may have diagnosis of depression, poor coping skills, social isolation. They may have few friends, little or no involvement in social activities, involved in crisis situations such as being unemployed, going through a divorce, and financial difficulties. Unrealistic expectations of the child may be present. Frequently, they will use harsh punishment. History of severe mental illness may be present with abusers. Violent temper or outburst. Looking to a child for satisfaction of their own needs for love and support. They may blame the child for his or her troubles. They lack effective parenting skills, inability to seek help from others. They may perceive the child as bad or evil. They possibly have a history of drug or alcohol abuse. They feel little or no control over their life and their life situation. They have a low tolerance for frustration and poor impulse control. So if you have time, go to the websites posted here on this slide. Again, any recent act or failure to act on the part of a parent or caregiver that results in death, serious physical harm, sexual abuse or exploitation, or any other act or failure to act that presents an immediate risk for serious harm. Please be aware of that definition and know that each state is responsible for providing its own definition of child abuse. Okay, overindulgence is that abuse or an abuse of a neglect. Children experience overindulgence, which is considered an abuse of neglect. It is an ongoing problem in industrialized countries. Financial resources have increased and family size has decreased. Overindulgence is a serious problem that results in social impairment, emotional stunting, particularly with empathy, physical problems caused by inactivity, and obesity. During the recent recession, more families have been slipping into lower socioeconomic brackets. Family stress is greatly increasing, which among some may lead to abuse. And as you know, with COVID becoming prevalent in our society, that has definitely increased stress. People have been left without jobs, and the potential for child abuse or any abuse has greatly increased. Assessing a child, here are the do's and don'ts. Again, you never want to lead a child into answering the way you want them to answer. We want to reassure these children that they'll not be punished and that they did not do anything wrong. They shouldn't feel pressured to talk about topics that they're unwilling or unable to talk about. The experience should be non-threatening and supportive for the child. Interviews should not resemble a trial or inquisition. Preschoolers, again, may express experiences through playing out the incident, such as with dolls or drawings. And again, using open-ended questions. And here are some examples or some open-ended questions. Diagnoses or outcomes identification for child safety, injury, and risk for injury are primary diagnosis for these kids going through abuse. Other nursing diagnoses might include the disabled family coping, post-trauma syndrome, anxiety, fear, impaired parenting, acute pain, and delayed growth and development is very common, especially with severe violence in the family, and imbalanced nutrition, less than body requirements. Short-term goals for the child going through abuse would then again be to receive medical care immediately within 1 hour, notify proper authorities for continued safety, and provide safety until adequate home or family assessment is made. With a response team, the emergency department is usually where the first contact is made with the abused child and family. Nurses are legally responsible for reporting child abuse to the appropriate child protective agency. Social workers, medical and mental health professionals, teachers, and child care providers are also legally responsible to report. Interventions include using a non-threatening, non-judgmental relationship with the parents. Understand that children do not want to betray their parents, so it's hard for them to talk against their parents. Provide or have a physician provide a complete physical assessment of the child. Using dolls, again, might help the child show you how the incident took place. Follow-up care, early diagnosis has a better outcome. Substance abuse, we know, is often found in abusive families. And additional related factors are mothers abused as children or who are abused by a partner are more likely to abuse their own child. Single parents, teenage parents, parents with mental retardation or disorders, a vulnerable child, such as with the unwanted pregnancy or a low birth weight baby, and a child that is difficult to care for as a result of a physical or a mental handicap, such as hyperactivity or colic. All these are definitely high on the vulnerability list. Know that there are strong links with family and community support, opportunities for parents to feel empowered through support groups, enhanced coordination of family services, emergency parental support 24 hours a day, Parenting, coping, and anger management groups are available. Normal child developmental education. It's a gathering place for parents and children, and community awareness of healthy parenting. That should be what's included with a child abuse protection program. So you need to kind of be aware of the reporting policies of a particular state or an agency. Contact the supervisor or social worker to report, such as the Child Protection Services. Ensure proper procedures that are followed with evidence that's being collected. So a physician, especially trained nurse examiner, can collect evidence from an assault or from an abusive case, and that evidence can be used in court. You want to ensure proper procedures are followed when you collect the evidence, and keep accurate and detailed records of the incident as it is told to you. Statements are written down verbatim of what happened, who caused the injury, when it occurred, word by word, it's written down. A body map is used to indicate the size, the color, the shape, and areas of bruises, injuries, other injuries, lacerations, anything. Photographs are often used to take pictures to be, again, show the same evidence, show the evidence where it was located, where it was obtained from, and it's also used in court used in court to hopefully put the perpetrator away. Intimate partner violence is the #1 cause of emergency room visits by women. It's drastically underreported. Between 22 and 39% of all US women experience battering worldwide. The worldwide rate is 69%, and that was back in 2015. Prevalence of domestic violence by women against men has increased. It also occurs in gay, lesbian, bisexual, and transgender communities. It's the leading cause of homelessness among women. Intimate partner violence is the leading cause of injury-related deaths during pregnancy. And birth defects and infant deaths are the frequent outcomes of abuse during pregnancy. Teen violence, forms of teen abuse, extreme possessiveness, jealousy, stalking, manipulation, devaluation, humiliation, threatening suicide, unwanted touching, and forcing intimacy or sex. Those are types of violence seen in teenagers. With intimate partner violence, this has severe, long-reaching effects. Children who reside in homes where intimate partner violence occurs are vulnerable to feelings of responsibility, to guilt, emotional distress, and behavioral regression, somatic complaints, PTSD, alcohol or drug abuse, and other. Children living in an atmosphere of intimate partner violence are 30 to 61% more likely to be abused. And children from violent homes are more likely to model the actions they see around them and carry the legacy of violence forward. An abusive relationship is all about instilling fear and wanting to have power and control in a relationship. Women are much more likely to be victimized than men. The battered partner does not ask to be beaten or does not enjoy being hit, lives in terror. does not usually initiate the violence, but when aggressive toward a violent mate, it is usually in self-defense. They usually have feelings of powerlessness and low self-esteem, and they greatly lose their sense of self. Violence and pain will remain a secret with them, and approximately 93% of women who kill their mates have been battered by those mates. The battered partner believes if she or he does or says the right thing, then the abuse will stop. They believe that if she or he does not do anything wrong, then the abuse will not happen. They contemplate suicide, sometimes contemplate suicide, or they may even contemplate homicide. Occasionally, they'll contemplate homicide in self-defense. Frequently, they lose their job as a result of the partner stalking or harassing them so much. Control through intimidation. This instills fear through threats. They will break things, destroy property, abuse pets, display weapons, threaten the children, and they may threaten homicide or suicide. Control through economic abuse, controls the money. If the partner works, the batterer calls excessively and forces the partner to miss work and end up losing their job. Control through power. They make all the decisions. They define the role in the relationship. They treat the partner like a servant and takes charge of the home and the social life. Violence is a learned behavior, and it's used to control others. Frequently, violent partners were brought up in an abusive home. Batterer has a low sense of self, poor impulse control, and a limited tolerance for frustration. Abusing a vulnerable partner helps the violent partner feel more in control and powerful. Men who batter have no guilt. They lack concern over their aggressiveness. They appear well-adjusted from the outside, and they're extremely possessive, pathologically jealous, and they believe in male supremacy. Often they have a drug or alcohol problem, but neither is the cause of the abuse. It's an excuse for abuse. The batterers with dissocial tendencies are thought to be more lethal than those with less psychopathic actions. Treatment approaches for batterers are not highly effective. This is a cycle of violence. Shows how it goes around, continues. The tension building stage, the acute battering, and then the honeymoon stage. And here's another picture of it. And just continues in a circle. So we often say, why in the world does that abused partner stay with them, or why don't they get away? Most of the time, there's no other means of financial support that's available if they did try to go away. No support system exists after living so long in isolation. They've lost all their friends. They've alienated their family. They're afraid to be alone, or they think they cannot survive without the partner. They're in depression, and they've lost the psychological energy necessary to leave. And also self-esteem is very low. They believe the batterer is powerful and omniscient. Some women may leave or may also believe that they deserve the beatings because they did something wrong. They can control the beatings by not doing anything to upset their partners, and they think they need to stay for the sake of the children. Or they may say that they're still positively reinforced by the honeymoon phase of the battering cycle. So in other words, it's worth going through the being battered because they're still happy in the honeymoon cycle or honeymoon phase. All All right, so assessing these women or these victims, women are the most often seen in the ED, but they can be men also. Sometimes they're seen in physician offices or in the clinic. If injury does not match the explanation, or if the patient minimizes the abuse, then you might want to suspect intimate partner violence. If intimate partner violence is suspected, then complete a physical history, including an X-ray study and a neurologic examination. Rape may be part of the abuse. Be sure and evaluate, especially if the woman is pregnant, exposed to sexually transmitted diseases, or has signs of infection or trauma. Signs of abuse can include burns, bruises, scars, other wounds in various stages of healing, and particularly around the head and neck. Excuse me. Physical examination includes assessing internal injuries, such as concussions, perforated eardrums, abdominal injuries, eye injuries, and strangulation marks on the neck. You want to assess for broken or fractured bones, arms, look at the arms, the pelvis, ribs, clavicles, legs, and jaws. Jaws are big ones. Examination might reveal burns from cigarettes, from acids used, scalding burns from liquids, or appliances such as irons. I've seen iron burns, unfortunately. Psychological and emotional scars. So presenting signs might include high anxiety, stress, and the complaint of insomnia, not sleeping, chest pain, back pain, dizziness, upset stomachs, trouble eating, severe headaches, and others. Assessment for post-traumatic stress disorder should be part of your evaluation. A brief history may reveal a series of falls or supposedly accidents and recent emergency room visits. When assessing, 3 questions are usually good or sufficient to reveal intimate partner violence. And those are, have you been hit, kicked, punched, or otherwise hurt by someone within the past year? And if so, by whom? Do you feel safe in your current relationship? And is there a partner from a previous relationship who is making you feel unsafe now? Always ask children if they're being hurt. If you get a positive answer, or a positive answer is suspected or confirmed, then contact Child Protective Services. Assess the patient's support systems, suicide potential, and coping responses. Document verbal statements and physical findings as outlined in the forensic part of interventions. Ask the woman if she will allow photographs to be taken for documentation. Identify whether the patient is interested in pressing charges. If they are, then give verbal or written information on local attorneys who handle spouse abuse cases, legal clinics, or battered women's advocates who will help them through that process. If the patient's not ready to take action, then provide a list of community resources, such as hotline numbers, shelters, battered women's groups, battered women's advocates, aid to families and dependent children. A lot of times a crisis intervention center will help house these women, even if they don't report at this time or want to take legal action. If they are sexually assaulted, these victims can have an examination completed, whether or not they're going to report the incident. Okay, so nursing diagnosis for intimate partner violence. You want to use immediate attention to the risk for violence and injury, any pain that they're having, so acute or chronic pain, risk for trauma, risk for self-directed or other directed violence. And then other diagnoses to consider would be social isolation, disturbed sleep patterns, powerlessness, disturbed personal identity, risk for post-trauma syndrome, and disabled family coping. So this is knowing kind of what you think and how you would react in certain circumstances before being put into that position is something that's good to know about yourself. We have to be comfortable with how we feel before we can really make others comfortable. So women who are treated in the emergency department may admit to intimate partner violence, but seldom do they come for treatment, and even rarer do they file charges. Nurses often have strong reactions when children or women are abused, and they come in and they appear helpless, they're hurt, and you just want to do more than we can really do. So kind of know how you feel about that. In the case of partner abuse, it's up to the abused partner to make the decision to stay in the situation or to leave the situation. It can't be decided for them. We can encourage them, but you can't make them go until they're ready. To be most helpful to the women, the nurse must accept their decision in a non-judgmental way and support the women in that decision. You want to help support her whichever way she goes, however you can. So you want to encourage them to have a safety plan, and they can move to a room with more than one exit so they can get out easier. Avoid rooms with potential weapons, such as kitchen knives in the kitchen. Know the quickest route to get out of the home. We want to know the quickest route out of their workplace. Find out where resources that can help protect employees, such as maybe security guards walking them to their car. Tell the neighbors about the abuse and ask them to call the police when they hear a disturbance, or like I mentioned in class the other day, when you decide on a particular code, such as the front porch light being on. We want to have a code word to use with the kids, with family and friends, so they know what's going on. Have a safe place selected in case you have to leave. You want to tell them to have a bag packed beforehand that they could grab quickly and take essential belongings with them, such as clothes or anything valuable, birth certificates, driver's license, things that they would need to even have a physician examine a child, and needs to be with the parent, with the mother, if that's who's leaving the situation. Prepaid phone cards, cell phone, an address book of your family and friends with phone numbers, and a 1-month supply of medications that you or your children may be on. Keep this in a packed bag where it's easy to grab and get to and get away with. So it should also be small. Legal documents, like I said, birth certificate, social security cards, a photo ID is important to have. If you have passports, have those. If you are on Medicaid or welfare, have that identification with you. Your green card, if you have one of those, a marriage certificate, any restraining orders that you might have, health insurance cards and papers, medical cards, records and papers, and school records, as much as you can have. Investment records, if that's available, with account numbers of your checking account, your savings account, and other accounts. Rental agreements, if you're renting a house and it's in your name, you want to have that paper with you. House deed and registration, and other important documents that you might need and might have trouble getting a hold of after you leave. Here's some programs for batterers, how those people can get help. Some focus towards eliminating violence and alternatives to fines and incarcerations. First priorities is protect the victims and make the offenders accountable. And they address the need to exert control, and we're going to change the batterer's self-perception if possible. Address the abuser's history, especially if they have been a victim. Cognitive behavioral therapy, about 85% decrease in abusive behavior with that. Okay, elder abuse. Elder abuse, unfortunately, is very much more common now than it was even 10 years ago. It's serious and rapidly growing. With the wave of baby boomers, an overwhelming number of older adults, 65 years and older, will affect the next decade and beyond. So the healthcare system is unprepared for this load of elderly. 6% of older adults are mistreated each year, and between 70 and 80% of incidents of elder abuse are never reported. The World Health Organization in 2015 stated that elder abuse is a violation of human rights and a significant cause of injury, illness, lost productivity, isolation, and despair. Elder abuse falls into one of three common categories. It's either domestic, institutional, or self-neglect. Physical abuse, again, infliction of physical pain or injury. Emotional abuse, causing mental anguish. Financial abuse or exploitation, misuse of someone else's property or resources, money. Neglect is failure to fulfill a caretaking responsibility and providing goods and services. Oh, sorry, I jumped down one. Neglect is the obligation to provide goods and services failing. May also include self-neglect. Sexual abuse is non-consensual sexual contact. This can happen at home and in the nursing homes as well. So older adults have to be deemed unable to care for themselves to be eligible for Adult Protective Services, APS. Eligibility requirements leave many who are healthy unprotected from family exploitation. Definitions in APS, they differ from state to state. Widely differing definitions make it impossible to know the extent of the problem. So conducting a sound study remains difficult in this situation. There is a national movement to standardize the approach in the study of elder mistreatment. People older than 80 years of age are 2 to 3 times more likely to suffer abuse and neglect. Victims are 3 times more likely to die than older adults who are not mistreated. Older women are more likely than men to suffer abuse and neglect. Majority of victims are white. With the abuser, research indicates that the abuser closely resembles the abuser in intimate partner violence or in child abuse. But the elder abuser may not be cruel or insensitive, but under extreme stress. Caregivers are usually under very much stress. Abuser is often a middle-aged child of the victim. Often the caregiver is financially dependent on the older adult. So in order for the adult child to care for the elderly, they have to give up their job and maybe move into the home with the elderly parent, therefore relying on the elderly parent's income to be able to do that. In many cases, the caregiver is dealing with mental illness, substance abuse, and inability to cope. Nurses have to determine the interventions, which includes the possible removal of the victim from the home. Signs of abuse are very similar to those that are abuse and intimate partner violence. Additional red flags may include fear of being alone with the caregiver, obvious malnutrition, bed sores or skin lesions from being left unattended, begging for food from not being fed, being hungry. They may need medical and or dental care. They may be left unattended for long periods of time. They may report abuse or neglect, or neighbors may also report this. Home health nursing aides or nurses that visit may report it. They may seem passive, withdrawn, and emotionless. and concern over finances and missing valuables may be present. Diagnoses and outcomes for the elderly who are abused. Nursing diagnosis for abused older adults are much the same as they are with other cases of abuse, and those are risk for injury, chronic pain, anxiety, self-directed and other directed violence. Two areas particularly that apply to abused older adults are neglect and financial exploitation. So this is possible when the caregiver or the adult child use their income, the Social Security, may be cashing their checks and may be getting into their bank accounts as a caregiver and using the money when they shouldn't be that way. Here's some interactive websites if you have time to look at those regarding elderly abuse. Okay, chapter 23. Suicidal thoughts and behaviors. So we want to assess for suicidal possibilities. We want to assess an intent to commit suicide, a plan to commit suicide, the means. Are they able to get a hold of what they need to in order to carry this out? Lethality of the means and previous attempts, if they've had any. Verbal cues, you want to assess those. They may be direct statements by the person or indirect statements. We want to assess for presenting symptoms, medical and other psychiatric diagnoses, such as mood disorders, like major depression and bipolar disorders. Those are the most common that go along with suicide. We want to assess the risk factors that may be present. Here are some nursing diagnoses used for suicide. Suicide precautions that you would take: secure the room, make sure the windows are locked, break-proof glass. You're going to use plastic spoons and plates of flatware instead of metal. You want to make sure all the cords are out of reach, or they can't get a hold of any, and there's none in the room, such as cords that hang from curtains, phone cords. Remove belts, matches and cigarettes, and anything sharp like razors. Patient care is frequent observation. A lot of times these people who are contemplating suicide will be a one-on-one. Staff communication. We want to develop a therapeutic relationship with that patient, a trusting one. We want to have them sign a contract that they're not going to try to commit suicide that day or that however long. We may have to use restraints as they are ordered, medications, and then monitor and restrict visitors. All right, so information for family and friends. We want to tell them to be sure and take suicide, any mention of suicide seriously. Don't just wave it off as another statement or another attempt. Report threats of suicide immediately. Listen. We want to listen more than talk and stay with the person that's threatening suicide. Express your concern about their welfare. Restrict access to firearms and anything else that they could use to harm themselves. And we want to help them become hopeful, instill hope, and express love for the person. We want to get them professional help and always address them in a non-judgmental way. For the survivors of suicide, we want to encourage them to talk about it. Be careful. We don't want to use any blaming or scapegoating. Listen again to feelings of guilt. Encourage them to discuss relationships with, Encourage discussion of relationships with lost loved one. Encourage grieving. Discuss coping strategies and identify resources that will provide support to the person. So evaluation is ongoing. Reassessment is continuous to assess whether the goal has been achieved or not. Okay, one more chapter, chapter 24, a little bit about anger, aggression, and violence. So anger is an emotional response to a frustration of desires. It's a threat to one's needs, emotional or physical, or a challenge. Aggression is action or behavior that results in a verbal or physical attack. Universal differentiation among the terms anger, aggression, and violence is difficult, if not impossible, because of the perceptions and social backgrounds. Anger is a normal and not always logical human emotion. No judgment needs to be passed on it. Anger varies in intensity from mild irritation to intense fury and rage. Aggression is not the same as violence. Aggression may be appropriate, as in a self-protective way, as in protecting yourself or your family. Protective, as in protecting yourself from being bullied. And then in the act of initiating hostilities, is the act of initiating hostilities. Never mind, that doesn't make sense to me what I'm looking at. Just forget that. Just know that sometimes aggression is appropriate, and that's with protection from or of yourself or of your family, such as when being bullied. Okay, so violence does not always have its roots in anger, but it does have the discrete intention of doing harm to a specific person or group. And it connotes extreme unjustifiable aggression, violating social sanctions, and causing destruction to another as it is planned result. So violence is defined as an unjust, unwarranted, or unlawful display of force. It is intended to inflict harm, damage, or to violate someone or something. Bullying is offensive, intimidating, malicious, and condescending behavior designed to humiliate someone. It's usually persistent, systematic, and ongoing. It's an intentional display and use of violence, as subtle as it might appear in some instances. So it can be very obvious or subtle. The term bullying is often used when a person or group has power over one another. Lateral bullying is bullying by a person of equal status. Okay, so is there bullying in the nursing profession? ANA survey of nurses, health and safety in 2015, 21% reported significant level of risk for violence at work. 25 to 50% reported experiencing bullying at work. 50% reported verbal or nonverbal aggression from a peer. And 42% reported verbal or nonverbal aggression from a person in a higher authority. So behaviors of bullying in the nursing field: unwanted or invalid criticism, excessively monitoring of another's work, gossiping, spreading lies or false rumors, and or assigning derogatory nicknames, taking credit for another person's work without acknowledging the contribution or blocking career pathways and other work opportunities. Public derogatory comments about staff members or their work, including the use of body language like eye rolling, dismissive behavior, often in front of others. Sarcasm, ridicule, and or making someone the target of practical jokes. Blaming someone without factual justification. Others, bullying sources, allocating unrealistic workloads and not supporting colleagues. Being condescending or patronizing. Physical or verbal innuendos of abuse, foul language, raising one's voice, shouting, and or humiliating someone in front of colleagues. Broken confidences are also forms of bullying. Some attributes that may make one more likely to be bullied is being a new graduate or a new hire, receiving a promotion or honor that others believe is undeserved, having difficulty working well with others, receiving special attention from physicians, working under conditions of severe understaffing. Some attributes that may make one more likely to be bullied, again, being a new graduate or new hire is on the top of that list. Okay, prevalence and comorbidity. Post-traumatic stress disorder, substance abuse disorders, co-occurring illnesses such as depression, anxiety, psychosis, and personality disorders are a possibility. In the hospital, violence is most frequent in psychiatric units, emergency departments, geriatric units, and waiting rooms. More than half of nurses reported verbal abuse, and more than 1 in 10 experienced physical violence at some point. Post-traumatic disorder, we already covered that one. Low socioeconomic status correlates with high rates of perpetrators and victims. Childhood aggression is the strongest predictor of adult violence. A majority of perpetrators are males, aged 15 to 24 years. Setting fires, animal cruelty during childhood, or a diagnosis of a conduct disorder are red flags of future violence. Many violent adults also suffered violence in childhood with a family history of violence. Violence in clinical settings may be related to the abuse of alcohol and or other substances like intoxication or withdrawal. Poor populations experience alienation, discrimination, family breakdown, and survival reaction. Low socioeconomic status has a high rate of, again, perpetrators and victims. Learned angry reactions, family and or social norms. Don't forget about genetics also plays a part with violence, and neurobiological factors and brain structure. So no one site in the brain is responsible for anger and aggression. The hypothalamus and the limbic system do contribute to emotions. Stages of violence of the cycle: pre-assaultive stage, the assaultive stage, and then the post-assaultive stage. You need to know your unit and hospital's protocol for secluding and restraining in the part of the hospital that you work, if that needs to be done. Okay, that would be it.